Good morning, and thank you to the workshop planners for the invitation. Just relevant background, in addition to running the survivorship program at Memorial, I also chair the Hospital Ethics Committee and an IRB member. So I think that my perspective on some of this will be relevant. I was asked to be the workshop historian and to present and discuss with you the National Cancer Institute efforts with respect to consent initiatives in revising and improving, hopefully, the documents that are used in NCI-sponsored trials. With respect to the consent document, I think one could say that in the beginning and over many decades, there was the word, and then there were words, and then paragraphs, and over time, many, many pages. And so it has brought us to a point where researchers have, and many of the speakers this morning, have talked about the complexity, the length, perhaps even inaccuracies, and the very high reading level that we see in the informed consent documents that we review and that our patients read and hopefully will perhaps understand. Very often, I think we're finding not. And just going back to Laura's presentation, let us keep, as I'm speaking, in mind this individual throughout the discussion, because even though we're talking about a form, the form is really only a tool to actually assist the individual in their decision-making about participation in a clinical trial. And so because of the length problems and lack of understanding with respect to these documents, the National Cancer Institute back in 1997 undertook an initiative to try and really improve these documents. It was a very large group that was put together, and I would say it was one of the most important times with respect to including patients and patient advocates in the process from beginning to end. And the FDA and OHRP were included certainly as advisors. The community included not only researchers, but ethicists, legal experts, and perhaps the first time communication experts, which made a huge difference. And I would say over this 2-year period that was quite long and somewhat protracted, that it was really the patient groups that brought us back to the drawing board over and over again and really reminded us about how to present information and what things were important to them in this document. And so the goals were pretty obvious: to simplify the form, using plain language to hopefully improve understanding, providing guidance that could be then disseminated nationally to IRBs and to researchers themselves, and really to promote the use of supplemental materials, not including them in the main text, but knowing that at the local level there were many educational materials, fine materials that had been made available. And of course, comply with federal regulations, that goes without saying, and provide some guidance to the process, knowing that the document is not itself a process. The shortcomings, I would say, that we understood over time was that it was focused specifically and only on cancer treatment trials for adults, excluded genetic testing and the increasingly important specimen banking. There was limited buy-in from industry, and I think all along that continues to be somewhat of a problem. There was no evaluation plan. Perhaps that had to do with resources, and perhaps we were short-sighted in thinking that we could solve a problem pretty simply. And there was really no audit plan. Did really people use this template, and what happened to it over time? And so, as you might expect, over time in the published literature, studies that had been done, and I just highlight a few of them, from Abala, among the problems. Again, we were back to excessive length, complexity of wording. Beardsley used the quick questionnaire that Steve Jaffe developed, which is a very nice brief questionnaire that looks at understanding and perception of information, and found that the scores were significantly higher for trials in which the page count was 7 or less. Steve himself did a study looking at the fact that and found that 63% of individuals didn't recognize the potential for incremental risk, and 70% didn't really understand the unproven nature of the treatment being evaluated in the study. Sharp looked at the consent documents and found that they were so long that the average patient is unlikely to read them, never mind understand them. And even AHRQ, as an agency, was very concerned and published a document in 2009 stating that they are too long and written as a reading level, well beyond the capacity of most potential subjects. And in the study by Beardsley, which was published in the JCO, what he found in his evaluation is that the median page number increased to 11 between 2000 and 2005. So again, this page numbering is actually a surrogate for the concern about, do patients understand the information that's being provided to them so that they can make an informed decision. And our colleagues abroad at EORTC, they didn't call them longer forms, they called them fatter forms. And again, finding the same issues and problems that we faced here in the United States. And so over time, there were increasingly requests from change that came from all of these constituencies. And I would say the primary voice, most important voice, were the patient advocate organizations, hearing from their patients that although they were interested in participating in clinical research, clinical trials, they really didn't understand what was being presented and proposed. And very often they were hearing both by phone, by email, that individuals were finding out later what actually had happened. The American Association of American Medical Colleges had a strategy meeting to try to really add to this dialogue and improve the consent document and also the consent process. AHRQ actually developed a toolbox to facilitate the consent for low-risk research. And the Institute of Medicine has long been a proponent of advocating for improved presentation of information and understanding. And even IRB chairs were questioning what's happening to these documents, what's my responsibility, who owns them, what should we be doing with them, and again, worrying about audits and how that might affect the way that they approach the informed consent document. And certainly investigators in the cancer therapy evaluation program themselves acknowledging that these documents were getting certainly longer, more complex, and really quite unwieldy. So who and what are the problems? Was there really a single source, in terms of figuring out what was happening? And a lot of finger pointing at each other as to where the culprit really was. But I would say that it's a multifactorial issue and it needs a number of solutions to actually make this an improvement so we don't find that it's a deja vu from the first NCI effort to look at the consent form in 1997 to now. And so the concern and the voice was raised that IRBs add too much unnecessary information, that at the local level they feel an obligation, and this has been commented on this morning already, to tweak it, add what they think is important information for their own local constituents. And then also investigators use too much medical information and jargon. At my own institution, I've seen, in particular young investigators who are trying very hard to submit their first protocol and their best protocol will actually cut and paste from the protocol itself. So in the part on why is this study being done with the rationale, you'll actually see a very long scientific summary of many paragraphs. Is that useful information to the person reading? I think we would all answer in the negative. The cooperative groups have made the forms complicated and too long, and IRBs brought this back, and I would say over time that did happen. If you actually match the template to many of the cooperative group consent forms, would find that they actually, although they use the topical areas, that there was many paragraphs and pages that have been added. And then industry wants a legal document. I think this comes up over and over, and although I'm only talking about the NCI initiative, we need to acknowledge that in this country, much of the clinical trial work with new agent development and devices is not done by NCI, but is done by private industry. And we really need to bring this group into this discussion. And so I want to just highlight a study that was done by Koifman, published in JNCI, where he looked at the heterogeneity of consent documents that were approved by IRBs after they had been received by the cooperative groups. And so here you see group A is the total consent document, B is the rationale for the study, C is the component on privacy, and D is the discussion of cost. And the black bar in each of these graphs is the reading level, Flesch-Kincaid grade level for each of these cooperative group studies as they were approved by the cooperative group. But the colored bars are actually what happened once the IRB at a number of cancer centers reviewed them. So you can see huge heterogeneity once the IRB received these documents and what they did with them prior to their approval. So again, the reading scores by and large going up rather than down after receiving them, or rather staying the same. In the same study, Koifman and colleagues looked at the page count, and again, the same thing happening. This is for cooperative group studies. The black bar is the grade level when it was approved by the cooperative group and sent out to the participating institutions, and the colored bars are various institutions and the grade level at which the document was approved on site. Again, do we need to be doing this tinkering? Is this useful? Is this helpful at the local site? And so in thinking about where to go next, because of all of this discussion on a national level by many constituencies, NCI, in thinking about reconstituting another consent document initiative, really looked through their own portfolio of phase 3 trials. They reviewed 97 of them. And as you can see here, the range of pages was from 5 to 35 with a median of 16. And so again, in 2011, another initiative was begun. The previous initiative, I was an NCI employee and was one of the co-chairs of the effort. And this one, I was one of the chairs of a working committee. And as you can see, they expanded greatly the groups involved, from diagnosis, imaging, as well as cancer control and cancer prevention, to add to the focus on cancer treatment trials. Again, FDA and OHRP were advisory and very involved in reviewing the recommendations that went forward. And in addition to these groups from NCI, I must say, not only were patient advocates, but the representative research communities were greatly involved as well. And so there were 5 working groups, and the first 3 related to the template itself that's been developed, looking very specifically at elements of background, required tests, interventions, highlighting risks and benefits and what should be in this section, because I think over time so much of the focus has been on defining the risks and listing any benefits that might occur. What are alternatives to treatment in this clinical trial, privacy, injury, cost, rights, and signature. But then there was also a focus on what attachments should be made available and what should be only an attachment rather than in the core document. And an interest in placement and language for companion studies. How do we think about these optional studies that are very frequently occurring in cancer trials? And so there were both challenges and controversies that occurred in the discussions and the meetings and the conference calls. And one of them was actually about having 2 titles. And this was an important item for the patient advocates, because so often the titles are meaningless and uninterpretable to the lay person and the person who's most important in terms of understanding. And I'll just read to you one of the suggestions on how to think about doing this of an official title that's used at cancer.gov, and then the lay title. So the official title of this study is a phase 2 trial of DCTD-sponsored dasatinib in a recurrent persistent ovary, fallopian tube, primary peritoneal, and endometrial clear cell carcinoma characterized for the retention or loss of BAF250 expression. The lay title for the individual who's going to be reading this and considering participation in the study is Testing Dasatinib in Advanced Ovarian, Fallopian Tube, Primary Peritoneal, and Endometrial Cancer. So again, the patients are telling us what's useful for them to know and how do they need to understand it. There was a lot of discussion about a brief discussion of usual care. This was very important also to the patients and patient advocates. And I felt it was met with quite a bit of resistance from the researchers, because often they would say, well, there's no one standard of care. So how do we begin to describe this in a way that makes sense without having a very long list of this option versus that option versus something else? And so over time, there was an agreement that it could be done in a very concise way with about 5 to 9 sentences. And I just read to you the usual care paragraph that's used with the that can be used with the study that I just gave you the title for. You are being asked to take part in the study because you have clear cell cancer of the ovary or endometrium which has grown or has reoccurred. People who are not in a study are usually treated with either surgery, radiation, or the following FDA drugs: carboplatin, paclitaxel, liposomal doxorubicin, or gemcitabine. Sometimes combinations of these are used, and your doctor can explain which may be best for you. These treatments can reduce symptoms and may stop the tumor from growing for several months or more. So again, this is helpful from the patient's perspective and is now included in the template that's going forward. Lots of discussion about procedures. What about usual procedures and the risks of those procedures? Should they be included? And over time, there was consensus that any usual care that a patient would receive outside of the clinical trial should not be part of the informed consent document or the consent document. Lots of debate back and forth about the language, lay language, and I would say we probably didn't come up with a good consensus, and it would be very useful to have some communication experts actually help us with things of how to refer to standard care. Is it the study doctor, the research doctor, and how do we do this? Correlative trials, should they be embedded in the document? Again, there was a consensus and agreement that anything that was optional should not be in the main body of the consent document. So lots of focus on risk presentation, as one might expect. And these risks were described from the participants' point of view and much easier to understand. If you looked in the template with the advisories that are included there, it really is extremely helpful. And I would say that going back to a paper that Paul Applebaum did reviewing the consent documents at his own institution over a 25-year period, he posits that one of the reasons that the documents have become so long and so complex is the increasing focus on risk. And because of the highlight of regulatory groups and also the public on making sure that the individuals who are considering participation in trials understand risk. So again, this is an important area. It may be over-highlighted, but it's certainly something that takes up considerable time and effort to do well and to do right. The template now proposes a consistent approach to discussing frequencies. Again, this is something that is important for us to know. How do people understand the frequencies? And the advice is not to use percentages, but rather to use a numerical summary of X number of individuals out of 100. And I'll show you an example of this in a minute. To format risks into tables, make them simple. And I think that the group did a very nice job with this. So in the risk section, again, our patients proposed to us and did tell us how important it was to describe non-physical risks. To also describe in an overall way, the laboratory tests will be monitored by the study physician, and then to make some important points about the side effects. And then getting down to the individual risks and side effects associated with the drug or the regimen, list them as common. Some may be serious, occasional, some may be serious, and rare and serious. And so I just show you the template that is proposed about how to do this. And the recommendation is not to list drug by drug when there's a regimen such as Folfox, because what an individual doesn't want to see and doesn't need to see is nausea written 3 or 4 times, alopecia written twice, but rather setting out the risks in a way that the individual experiences them. So some of the new features in this template versus the older one is that it includes a broad range of studies, as I suggested, in particular chemoprevention studies, behavioral studies, and imaging. There are length limits for the section. So for instance, in the section on the rationale, it suggests, and I would say that we probably should hold ourselves to this at the local IRB level, 5 to 9 sentences. So throughout the template, it suggests how long this that section should be, and I think that's a pretty important point that they're making because it will cause us to actually think about how to convey the information simply. In the text, there's actually very useful information about mandatory specimen collection and how to include optional studies as a very distinct separate component of the consent document. And so where are we now with this template? The status is that it's been distributed as of February of last year. The effective use date for CTEP-sponsored trials was May of 2013, and many of our IRBs are now working through how we're going to institute this institutional-wide. I can say that at my own institution, the IRB is incredibly relieved to see a template that gives such specific and important guidance. And what we hope to do is to be able to not only use this with our investigators in their training, but to actually evaluate ourselves over time so that the word drift doesn't become an ongoing problem. My understanding is that there was a call by the participants in this initiative for an evaluation, and that there has been a randomized study between the new and old version to actually see whether it's very useful. Does it actually improve understanding? And that these results are being analyzed. I spoke with staff at the Cancer Therapy Evaluation Program last year, and we don't have any results to share with you today. So where should the emphasis be? I've been talking about the forms, and certainly we all know that the form is only one part of this effort. What's critically important is really the process. And might we, in addition to this effort that NCI has so nicely put together, really think about how we might develop electronic toolboxes for short evaluation questionnaires? Might we put together for individuals for whom the word isn't very useful, but pictures are available, and make these available for IRBs. We can do so much more electronically to really improve the process. And also, how do we actually evaluate? Should it be part of our audit process rather than looking at whether the form is signed, whether the form has the right date on it, but also look and see, is the institution assessing understanding, and how are they doing it? Part of our training of new investigators, taking online courses understanding the regulatory requirements for clinical research, but are we giving them any information online in a short audio-visual of the importance of how to actually have this conversation? And we've talked a lot this morning about the regulatory infrastructure, and so might there be some things that can be taken away, and I think all of us are feeling that there are with respect to clinical trials oversight, at the same time that we improve, I think, some requirements with respect to improving the process. And so are we ready for the future? We've been hearing a lot about the learning healthcare system, about how did we think about consent for that, and we ought to really have more novel, interesting ideas about how to improve the consent process for traditional clinical trials as well. There's a whole new landscape out there, and we really ought to move beyond that paper form and thinking about it in the usual way. And so I just ask you, questions that for this meeting and I think going forward, and hopefully the National Cancer Policy Board can really, I think, be kind of an invigorating influence on the question of overemphasizing regulatory infrastructure. And also industry. Are we overlooking industry in this discussion? At my own institution, in 2013, we had 79 phase 1 trials and 53 phase 1/2, and most of those are being done with industry and not sponsored by the National Cancer Institute. And my third item is, should we focus more on education about how to communicate with potential participants rather than revising a document? And so what we don't want to have happen a decade from now is to have the same, I think, studies published, maybe with new authors and new dates. But rather what we need to do is understand that it's really not about the paper form, and it's certainly more than a signature. So thank you for your time.